So imagine you arrive at the emergency room with a suspected stroke, right? You'd probably assume the doctor's absolute first priority is to, rush in and save your dying brain cells.
Oh, yeah, definitely. I mean, it makes total sense.
Right, because every second ticks away and, well, thousands of neurons are lost. But you would actually be wrong. Their absolute first priority in that moment of crisis is to make sure they don't accidentally kill you.
It is the ultimate high-wire act in modern medicine, really.
Yeah.
When a patient is wheeled through those double doors, you cannot just guess based on their physical symptoms. You need immediate, undeniable structural data to tell you what is happening inside that skull.
Because giving the wrong treatment is, vastly worse than doing nothing at all.
Exactly.
Welcome to this custom-tailored deep dive. Our mission today is to decode the exact radiologic roadmap that doctors use for acute stroke assessment. We've got a stack of sources in front of us, including actual clinical notes and transcripts.
Yeah, and they detail the specific imaging framework that medical teams rely on when the brain is under attack.
Okay, let's unpack this, because imaging isn't just taking a quick picture to see what's wrong. It's a high-stakes decision-making tool.
Right, a tool that dictates immediate life or death treatments.
Exactly. So whether you're a medical professional catching up on your field or, just an insanely curious learner, this breakdown will demystify how modern medicine navigates a brain crisis.
It really is a fascinating process.
So we're starting with the first 30 seconds of this roadmap. Before doctors can fix the problem, they have to ensure their treatment won't make it worse.
Yeah, that absolute first priority. The medical team is looking for one thing above all else, which is excluding a hemorrhage.
Meaning they have to prove the brain is not bleeding.
Yes. That is the single most important initial hurdle you have to clear.
And let's offer a real-world analogy here for the listener. It's kind of like a firefighter checking a building for a massive gas leak before they just go breaking down a door with an axe, right?
That is a perfect way to look at it. You have to rule out a bleed before using your powerful tools.
Because the tool they use for an ischemic stroke, the blocked pipe kind of stroke, is thrombolysis.
Right. Those are incredibly powerful clot-busting drugs. Their whole job is to dissolve the clot and restore blood flow.
But if you give those to someone whose brain is actively bleeding,
you turn a manageable bleed into a fatal hemorrhage. You absolutely cannot give thrombolysis if there is blood.
So to verify this, the sources say the non-contrast CT scan is the very first step.
It's the undisputed workhorse. It takes less than a minute, it's widely available, and fresh blood shows up immediately as this bright white mass on the scan.
Okay, so let's say they run the CT and they don't see a massive bleed. Clear that first hurdle. But now they have to look for the early signs of the blockage, and the notes list some heavy jargon here.
Oh, the early ischemic changes.
Yeah, things like loss of gray-white matter differentiation, sulcal effacement, and obscuration of the lentiform nucleus. What does that actually look like?
Basically, they're looking for subtle swelling. When brain cells get starved of oxygen, their energy pumps fail, and water rushes into the cells.
Cytotoxic edema, right?
Exactly. The cells physically swell up. So on the CT, the sharp contrast between gray and white matter just blurs. The deep valleys in the brain. The salsa gets squeezed shut, which is the effacement.
So the brain's architecture basically turns mushy and indistinct.
Yeah, that's exactly it.
But the sources also mention the hyperdense MCA sign, which sounds a bit different.
It is. The MCA is the middle cerebral artery. Sometimes, before the tissue even swells, the CT spots the physical clot itself in the vessel. It shows up as a bright hyperdense line, which predicts a major large cortical infarct.
Wow. Okay, so doctors are looking for these blurry signs, and the notes bring up the aspect score to help make sense of it.
Yes, the Alberta Stroke Program, early CT score. It's a way to bring objectivity to a very subjective visual process.
Right. It divides that MCA territory into 10 distinct regions.
Exactly. A score of 10 means perfectly normal. For every region that shows that subtle swelling or blurring, you subtract a point. If you drop down to 0, that means extensive ischemia.
And the sources emphasize that this score predicts hemorrhage risk and 3-month outcomes with really good inter-rater reliability.
Which is so important when multiple doctors are looking at the same blurry scan.
But wait, the sources also say these early CT changes are often just a whisper and easily missed. Isn't it a huge common mistake to look at a normal early CT and confidently declare the patient is fine?
This raises an important question, and the clinical notes explicitly call this out. A normal early CT absolutely does not rule out an evolving stroke.
because the damage just hasn't swollen enough to show up yet.
Precisely. And that limitation perfectly sets up the need for the next technology in our roadmap because we are fighting the clock.
Right, because time is brain. Since the CT struggles with early detection, they need something more sensitive. But here's the real challenge. What happens when you don't even know what time the clock started ticking?
The dreaded wake-up stroke.
Yeah, if you wake up with symptoms, nobody knows if it happened 10 minutes ago or 6 hours ago.
And you can't just guess, because giving clot busters too late drastically increases the risk of a fatal hemorrhage.
So the notes describe a workaround using MRI technology. First, they talk about diffusion-weighted MRI, or DWI.
Yes, DWI allows for genuinely early detection. It is exquisitely sensitive to that water movement we talked about.
So while a CT scan might just show a questionable faint blur, the MRI's diffusion signal lights up the exact same lesion unmistakably.
Almost instantly, it reliably differentiates acute from chronic infarcts. It's like a spotlight on the dying tissue.
Here's where it gets really interesting, because to solve the wake-up stroke mystery, they use a concept called the vault, or the DWI flare mismatch.
This is a brilliant biological workaround.
So how does it work? You have the DWI that lights up immediately, and then another scan called flare, right?
Right. Flare operates on a delay. It takes several hours for a stroke to show up on a flare scan.
So if you scan a patient and the DWI is glowing bright white, proving there is a stroke.
But the flare signal is negative, meaning it looks totally normal.
That mismatch acts as a genuine clock substitute. It proves the stroke is still young, under about 4.5 hours old.
Exactly. It means the patient might still be eligible for thrombolysis, even though they were asleep when it started.
That is just incredible. But I have to push back here. If MRI is so much better, unmistakably lighting up the stroke while the CT barely whispers a hint, why do they even bother with the CT first?
That's a very fair point.
I mean, why not rush everyone straight to the MRI?
It comes down to logistics and our first prime directive, excluding hemorrhage. As the sources note, CT remains the fastest and most widely available tool to clear that hurdle.
Oh, because MRI machines take time to set up. You have to screen for metal, all that.
Yes. MRI requires time and resources that aren't always instantly available when millions of neurons are dying every minute.
Okay, that makes sense. So CT clears the bleed, MRI hacks the clock. We've established how doctors figure out when the stroke happened.
But modern medicine is actually shifting to a totally new paradigm.
Right, moving away from the clock and looking at what can actually be saved.
Exactly. And they do this using CT and MR perfusion imaging.
So they inject a dye and watch it flow through the brain, right?
Yes. It estimates two crucial areas, the ischemic core and the penumbra.
Okay, let's use an analogy for the listener. Think of the ischemic core as a house that has already completely burned down to the foundation. You can't save it.
The tissue is already lost.
But the penumbra, that's the neighboring houses, they're getting incredibly hot, they're at risk, but they haven't caught fire yet. They are still salvageable.
That's a great visual. And the automated software platforms calculate this rapidly as a mismatch ratio and a mismatch volume.
So what does this all mean for the patient? Does this mean some people who would have been sent home to suffer the consequences in the past are now getting treatment?
What's fascinating here is that this specific technology is central to modern trials that extend treatment windows way beyond traditional time cutoffs.
Wow.
Yes. Doctors can now select patients based on actual salvageable tissue rather than just watching the clock. It's a monumental shift toward personalized decisions.
That is huge. Okay, so once the immediate crisis of the brain is managed and that penumbra is saved, the doctors have a new mission.
Yes, investigating the rest of the body.
Right, to figure out why this happened so it doesn't happen again. The notes break this down into the plumbing, the pump, and the blood.
A very systematic approach. Let's start with the plumbing, the vascular system.
They use CT angiography, or CTA, and MR angiography.
Right. These visualize large vessel occlusions directly, which is essential if they need to do a mechanical thrombectomy to physically pull a clot out.
And for the neck plumbing, they use duplex ultrasound for carotid disease, right? The notes say it's 87 to 96% sensitive for severe stenosis.
It's a great first pass, but it has limitations. It struggles with distinguishing severe stenosis from full occlusion, and it can miss small, unstable plaques.
Which is why they don't stop there. If the plumbing is clear, they look at the pump, the heart.
The heart is a major source of blood clots. They start with a transthoracic echocardiogram.
An ultrasound on the chest.
Exactly. And if they need a better look at things like the left atrial appendage or the interatrial septum, they'll do a transesophageal echo going down the throat.
But what really caught my eye in the sources is the focus on prolonged cardiac monitoring. They specifically mentioned the Embrace and Cristo Reyes studies.
Those studies are practice-changing.
Why is monitoring the heart for weeks so crucial?
Because of paroxysmal atrial fibrillation, it's an irregular heartbeat that comes and goes. When the heart fibrillates, blood stagnates and forms clots, which then get pumped to the brain.
And you might completely miss that if you only monitor them for 24 to 48 hours in the hospital.
Exactly. Those studies proved that monitoring well beyond that time frame detects significantly more cases of this hidden AFib.
And finding that changes the whole prevention strategy, especially for what the notes call cryptogenic strokes, where the cause was unexplained.
Absolutely. You shift them to robust blood thinners instead of just standard aspirin.
Okay, so we check the plumbing, we check the pump, and finally we arrive at the blood itself. And looking at this list of labs, I mean, it's exhausting.
The thrombophilia panel.
Yeah. We just spent all this time staring at the brain, checking the neck plumbing, going down the throat for heart echoes, and now we are running a dozen obscure blood tests for things like factor V Leiden.
It was a lot, I admit.
Isn't this an overwhelming amount of data? How does it actually come together in a real patient?
It sounds overwhelming, but it is highly systematic. For selected younger patients or unexplained cases, you have to look for hidden genetic mutations.
Like antithrombin activity, protein CNS, prothrombin gene mutation, lupus anticoagulant. It's quite the list.
Right, because if their blood is inherently hypercoagulable, meaning it clots when it shouldn't, all the brain treatments in the world won't prevent the next stroke unless you put them on the right specific medication for their blood disorder.
Wow, okay, so it's about ultimate secondary prevention. Let's bring this all back to the specific patient case from the clinical notes to see the roadmap in action. So the patient's CT showed no hemorrhage.
Step 1 complete.
They had an aspect score of 9, so very minimal early damage.
Perfect candidate for intervention.
And then the CT angiography showed a clean cutoff in the M2 branch of the left MCA.
A definitive large vessel occlusion.
And the sources emphasized that this radiologic roadmap worked perfectly to confirm exactly what was suspected clinically from the very beginning.
It did exactly what it was supposed to do. It gave the surgical team the exact structural data they needed to go in and fix the problem.
It's just brilliant. But, you know, going through all this leaves me with a final, slightly provocative thought for you to mull over.
Oh, lay it on me.
Today, we use AI and perfusion software to extend treatment windows based on salvageable tissue, right? Moving away from the ticking clock.
Right. Focusing on the penumbra.
So if technology continues to redefine what is too late to save brain tissue, how might this fundamentally change the nature of emergency medicine in the next decade?
That is a wild thing to think about.
I mean, could the whole concept of a point of no return become a thing of the past? If we can perfectly sustain that tissue, maybe the clock stops mattering entirely.
I think we are definitely heading in that direction.
Definitely something to explore on your own. Thank you for joining us for this deep dive. We will catch you next time.